Assalamu alaikum, I'm Marwa Adil. We'll talk in this lecture about fetal physiology. Lecture objectives: talk about blood flow, pathway, and fetal shunts. We'll talk about fetal oxygenation, how the fetus thrive in low oxygen environment, explain development of the fetal lungs and surfactant production. Physiological changes occur at birth and hemopiesis with fetal hemoglobin or hemoglobin F characteristics. We'll talk about amniotic fluid composition, production, and elimination pathway. First, we start with cardiovascular system. Cardiovascular system develop early in fetal life during 4th week. The fetal heart differs from adult heart in that the four chambers of fetal heart arrange in parallel system via output of right and left ventricles mix due to shunts that normally close at birth. The circulatory system acts either parallel or series system. In fetus, it's parallel system, and in adult, it's series. How? Series system or series network, it acts like that. Blood flow from the heart to pulmonary system, to the lungs, then back to the heart, then circulate to the systemic circulation. It's okay? In series, one by one. It's one-way path. تمام? Unlike fetal heart, it acts as parallel system. Both right and left ventricles output mix in the systemic circulation. But in adult, blood from right ventricle pumped to the lung, to the pulmonary circulation, back to the left ventricle through left atrium, then circulated to systemic circulation in series. This difference between adult and fetal heart due to shunts in fetal circulation that will normally close at birth. These shunts are three: ductus venosus, foramen ovale, and ductus arteriosus. Ductus venosus is located between umbilical vein and inferior vena cava to bypass the liver. Foramen ovale is in the heart between right and left atrium to bypass right ventricle, and so will bypass the fetal lungs, which is not functioning intrauterine. The third shunt is ductus arteriosus, which connects pulmonary artery to descending aorta. The right ventricle will pump 10% of the cardiac output to the pulmonary circulation, which is non-functioning. تمام? This 10% will be bypassed by ductus arteriosus. These regions explained: ductus venosus, there is a V venosus, vena cava, umbilical vein. Foramen ovale in the heart between two atria, right and left atrium. The ductus arteriosus between pulmonary artery and descending aorta. And so the fetal circulation will be like that. The blood from superior and inferior vena cava will enter the right atrium and through foramen ovale will bypass the right ventricle. It's okay? To the left atrium. Part of that blood through tricuspid valve will enter the right ventricle to pulmonary trunk, and this part, which is almost 10%, will be bypassed by ductus arteriosus to enter the descending aorta. From aorta to the umbilical arteries, and blood flow from umbilical arteries to fetal placenta to be oxygenated again. Umbilical arteries, it's a branch from internal iliac artery. The internal iliac artery has two divisions, anterior and posterior division. The umbilical artery branched from this anterior division. As we explained, this fetal circulation oxygenates blood from placenta and through umbilical vein will bypass the liver via ductus venosus and enter inferior vena cava to right atrium. Also, blood from upper part of the body through superior vena cava will enter the right atrium to left atrium through second shunt, which is foramen ovale. Some of right atrium blood will enter the right ventricle through tricuspid valve and to pulmonary trunk via pulmonary valve. This blood enters the pulmonary circulation will bypass later by ductus arteriosus between pulmonary trunk and descending aorta. The blood from aorta will return to the placenta to be oxygenated through umbilical arteries. The oxygen concentration varies across the fetal circulation. High at the umbilical vein, the highest at the umbilical vein, and medium oxygenation almost throughout the fetal circulation. Oxygen concentration in the fetal arteries almost 40 to 60% only. This is a physiological hypoxia. How fetus tolerates this fetal hypoxia? The mechanisms to ensure adequate oxygen delivery are preferential delivery of oxygen-rich blood to brain and heart, myocardium and brain, by the presence of the shunts, and delivery of the deoxygenated blood to the placenta for oxygenation. Fetal heart rate significantly higher than adult pulse rate, nearly doubled. Fetal heart rate can be reached up to 160 beats per minute. This increase in heart rate will ensure adequate oxygenation by raising the cardiac output. As cardiac output in equation calculated by multiplying heart rate by stroke volume. So increase in heart rate will also subsequently increase the cardiac output. Last mechanism to ensure adequate oxygenation is fetal hemoglobin. Fetal hemoglobin has higher affinity to bind to oxygen more than adult hemoglobin, and this will help fetus to extract hemoglobin from maternal circulation. The mechanism to ensure adequate oxygenation was the presence of shunts to ensure oxygen-rich blood to vital organs, and the presence of placenta for oxygenation, higher fetal heart rate, and fetal hemoglobin per se. What the physiological change or transitions occurs at birth? Okay, at birth, by clamping umbilical cord, the placental circulation will be lost, and systemic vascular resistance will be doubled due to sharp increase in aortic pressure. This increase in aortic pressure will close foramen ovale and ductus arteriosus shunts and enforce blood to flow through the pulmonary circulation. At the same time, with the first breath of air, the lung will expand and pulmonary vascular resistance will fall. This will ease the flow of the blood to pulmonary circulation. As the end result, with the increase in systemic vascular resistance and fall in pulmonary vascular resistance, this relative pressure difference will change the blood circulation from biliary system or biliary network to series, and from placental respiration to pulmonary respiration. And so, ductus arteriosus will close spontaneously on average 2 days to form ligamentum arteriosum, whereas ductus venosus will close by 3 weeks to form ligamentum venosum. While foramen ovale, the functional closure will occur at birth, but anatomical closure will delayed up to 1 year. Also, umbilical vessels will close to form ligaments. Umbilical cord composed of 2 umbilical arteries and 1 umbilical vein. The paired umbilical arteries will obliterate to form medial umbilical ligaments, which is located in the inner aspect of the anterior abdominal wall. But the proximal portion will form the superior vesical arteries, which supplies the upper part of the bladder. While the umbilical vein, which is a single vein, will become ligamentum teres hepatis in the falciform ligament of the liver. This is the cardiovascular system. Regarding fetal respiratory system, the fetal lungs develop in 5 stages: embryonic, pseudoglandular, canalicular, saccular, and alveolar stages. In the embryonic stage, there is a lung bud which forms the foundation for bronchi, followed by the glandular stage. In this stage, there is a branching of bronchioles and vascular component begins. Then canalicular stage. These bronchioles formed in the pseudoglandular stage called terminal bronchioles will develop into respiratory bronchioles in canalicular stage, increase vascularity, and start of surfactant production. The fourth stage is saccular stage, in which there is saccules or primitive alveoli, an increase in surfactant production. The last stage, alveolar stage, in which primitive alveoli will develop into mature alveoli, and this stage will complete it at childhood up to 8 years by increasing septation of alveoli and multiplication. As we say, the development of lungs not fully completed until the childhood up to 8 years. Fetal lungs in utero filled with fluid, and this fluid produced by lungs itself. This fluid is essential for lung development, and if it's decreased in volume will result in lung hypoplasia. We'll talk about surfactant. Pulmonary surfactant is a lipoprotein complex produced by type 2 pneumocytes, which is in alveoli, made of phospholipids and proteins. The lipid composed of 90% almost, mainly dipalmityl phosphatidylcholine, and the remaining 2% will made of proteins. The surfactant coats the alveoli to reduce the surface tension and prevent lung collapse. Also decrease the effort of breathing, increase in the pulmonary compliance, and allow normal inflation. Transition events are birth. Even before birth, the lung fluids will start to be reabsorbed from alveolar space into lymphatics and capillaries. And by first breath, air enters the lungs, so form what we call air-liquid interface in the alveoli. The surfactant adds to decrease surface tension, to prevent lung collapse, and facilitate breathing by increased lung compliance. Pulmonary fluid continuing to be replaced by air within 2 hours of breathing. Third system we'll talk about is fetal hematology. Fetal hematopoiesis has 3 overlapped periods: mesoplastic period, hepatic, and myeloid period. The first is mesoplastic period in the yolk sac from 14 days, it's 2 weeks, up to 12 weeks. The hematopoiesis occur at the yolk sac, followed by hepatic period from 6 to 18 weeks, myeloid period in the bone marrow from 8 weeks and throughout adult life. So it's overlapping periods. It starts with mesoplastic in the yolk sac, hepatic in the liver, and finally myeloid period in the red bone marrow throughout the adult life. The hemoglobin in the fetal life during development start with embryonic hemoglobin, then replaced by 10 weeks by hemoglobin F, which is called fetal hemoglobin. Fetal hemoglobin consists of 2 alpha and 2 gamma chains. The hemoglobin F or fetal hemoglobin will be the predominant hemoglobin type from 10 weeks up to the birth and peak at 32 weeks. After birth, it present in the circulation in lower percentage up to 6 months. Then will be replaced by adult hemoglobin, which is made by 2 alpha and 2 beta globin chains. First, embryonic hemoglobin, GOR1, GOR2, and Portland, hemoglobin Portland. By 10 weeks, it's replaced by fetal hemoglobin, 2 alpha and 2 gamma chains. Peak at 32 weeks up to the birth. Then, after birth, it's replaced by adult hemoglobin. Adult hemoglobin composed of 2 alpha and 2 beta globin chains. The replacement will be completed by 6 months. In the adult circulation, there is 1 to 2% of hemoglobin F, but the predominant type is hemoglobin A. Oxygen affinity of fetal hemoglobin. For sure, all forms of hemoglobin will bind oxygen but differ in affinity. Hemoglobin F binds oxygen higher than hemoglobin A. This is because hemoglobin A or adult hemoglobin binds to 2,3-diphosphogylycerol. This binding will reduce the oxygen affinity of hemoglobin A. This difference in oxygen affinity will allow hemoglobin F to transfer or extract oxygen across the placenta from maternal circulation. Graph demonstrates oxygen saturation curve, which will represent the difference between hemoglobin A and hemoglobin F in oxygen affinity and oxygen binding. The oxygen saturation curve is therefore shifted to the left for hemoglobin F when compared to hemoglobin A. Shifting to the left is increase in oxygen affinity, and shifting to the right decrease the oxygen affinity. Acid elution of fetal hemoglobin and Kleihauer test. We'll talk about Kleihauer test, which is represent other difference between hemoglobin F and hemoglobin A. Hemoglobin F more resistant to alkali denaturation and acid elution than hemoglobin A. This is forms the basis of Kleihauer test, a blood test used to detect and quantify fetal RBCs in a maternal circulation to diagnose fetal-maternal hemorrhage. This is important in rhesus-negative mothers. So, Kleihauer test diagnose fetal-maternal hemorrhage and determine the dose of anti-D immunoglobulin prescribed. Type. In this test, maternal blood smear is prepared and exposed to acidic solution. In acidic media, hemoglobin A will be soluble and hemoglobin F will remain intact. And hemoglobin F will turn pink, so fetal RBCs can be seen in microscope, while hemoglobin A containing maternal cells appear as pale or ghost cells. A simple count allows estimation of amount of fetal RBCs in maternal circulation, as may occur after fetal-maternal hemorrhage. This is the ghost cells, which is contain hemoglobin A, and pink staining cells, who contain hemoglobin F. Regarding fetal immune development, the precursors of immune system develop in embryonic yolk sac, then migrate to liver, spleen, bone marrow, and thymus. In the thymus, the lymphoid cells will mature and develop into T cells, while lymphoid stem cells in the liver and bone marrow will form B cells. B cell will produce immunoglobulin by maturing into plasma cells. There is 5 types of immunoglobulin: IgA, IgG, IgM, IgE, IgD. All the synthesis of these immunoglobulin begin at 12 weeks but remain at low throughout fetal life. Only IgG, maternal immunoglobulin G, is crossed the placenta to the fetus to provide passive immunity. Other 4 types of immunoglobulin not crossing the placenta either, due to large size, like IgM, which is a pentametric molecule composed of 5 subunits, so this large size prevent the cross of placenta. Other immunoglobulins not cross the placenta due to absence of receptor that allows the passage through the placental barrier. So the presence of immunoglobulin in fetal or neonatal circulation indicate intrauterine infection rather than maternal transfer. Renal system develop early in fetal life and urine production begin at 10 weeks. By 18 weeks of gestation, the fetal urine is a major component of amniotic fluid. In spite of that, unlike the adult, only 2% of fetal cardiac output for renal perfusion, because of fetal electrolyte balance is mainly controlled by the placenta rather than the kidneys. In gastrointestinal system physiology, although nutrition provided by the placenta, but the gut developed and swallowing occur at 12 weeks. The rate of swallowing increases with gestation age and make an important aspect of amniotic fluid volume regulation. While the fetal liver is mainly hemobiotic organ, the metabolic processes handled by the placenta. Fetal skin physiology. The skin is permeable to water up to 20 weeks of gestation, then decrease by keratinization of epidermis, increase in connective tissue, and formation of vernix caseosa. The vernix caseosa is a thin fatty film formed from 17 weeks made up of sebaceous gland secretions and desquamated skin cells. This white layer covers the baby is vernix caseosa. It acts as physical barrier from infection, natural moisturizer, also ease the birth thermoregulatory mechanism, and help in wound healing. Amniotic fluid is liquid surrounding fetus within the amniotic sac during pregnancy, has thermoregulatory, nutritive, and protective function, allow fetal movement and lung development, produced dynamically throughout the pregnancy, initially from maternal plasma ultrafiltrate and transferred via fetal skin before cretinization at the first half of pregnancy. Then, from the 18 weeks, it's mainly formed from fetal urine and lung secretions. So, amniotic fluid acts as shock absorber, infection control, temperature regulation, fluid balance, and for fetal movement and lung development. Amniotic fluid completely replaced in few hours allow for rapid turnover. The amount of amniotic fluid varies across the gestation age. At the 12 weeks, only 50 ml, peak at 34 weeks up to 1000 ml, then decrease to 500 ml at term. The clearance or removal of amniotic fluid by fetal swallowing, which is the primary method of removal. The fetus swallows the amniotic fluid, then absorbed into bloodstream. Other method of clearance is intramembranous pathway, in which the fluid transported across the amniotic membrane into fetal blood. These abnormalities of amniotic fluid include abnormality in volume, either by decrease or increase in volume. Decreased level of amniotic fluid is called oligohydramnios, and excessive amount called polyhydramnios. Other abnormality in color. Typically, amniotic fluid is colorless, will be green in case of meconium stain in liquor. Meconium is a fetal fecal discharge, which indicate fetal distress. While red or bloody amniotic fluid during labor is a significant finding, maybe indicate placental abruption, uterine rupture, or vasa previa. Also, brown amniotic fluid may suggest fetal death or intrauterine fetal demise. These abnormalities of amniotic fluid. By this, we reach the end of this lecture. Thank you.